Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Hey everybody, welcome back to CCTPC. For those of you keeping track, that is the Collaborative Corner, the podcast. This week I have a guest that I'm going to be bringing in very shortly, but I always kind of try to give you a little amuse-bouche, and that's French for something. Not really sure. Somebody could look it up and tell me. I think it means something for your mouth, their small mouth. I don't know. We'll have to ask our guest. Maybe he knows. He can Google it while he's waiting for us. So one thing that I'm kind of excited about is we are actually in the middle of a clinical trial, and we're actually working with a biotechnology company, Opus Genetics, which has provided updates on what's called the LYNX-2 study. So, you have patients who have had LASIK surgery or RK, any corneal refractive procedure. They come into your practice and they're like, yeah, I've got glare, I've got halos. And I'm like, you know what? Maybe, if you've got halos, then you're an angel. Then, you deserve that. But the glare and halos, I think it kind of goes back a little bit to when we did LASIK surgery back in the day. We're using a kind of a standard diameter. We didn't have small spot, or just by virtue of the fact that we treated patients that probably never should have had surgery. Their cornea is too flat or maybe too steep. But this is using phenylalanine ophthalmic solution. For those of us keeping tracks, that's POS, 0.75%. And what's exciting about this is that it's getting fast-tracked for enrollment for patients who have glare and halos. The study just kind of completed, so I'm hopeful that this is going to be an opportunity for us to provide essentially the same type of medication that we use to reduce dilation. I don't know if you're familiar with Resume-V, adorable name, right? It's just, resume your vision, Resume-V, super cute. But we'll see how this works to reduce create a myotic pupil at nighttime so patients reduce some of that glare. So kind of excited to see how that goes. This thing's fast-tracked, so hopefully it'll get approved relatively soon. Something else that if you're not using in your practice is using lacquer fill. I'll have to ask my guest if he's using that. That was another clinical trial that we did. This is from Nordic Pharma. And for those of us that have implanted or inserted punctal plugs through the years, I still suck at putting in the upper lids. And as somebody who's become presbyopic, to actually have to kind of put the plug now on the plug inserter, it's insane. I have to go grab some +5s. I cannot do it in front of the patient because it's embarrassing. Sometimes I'll bring a tech in and just act like it's, it's this massive procedure. But yeah, those upper lids, man, those are insanity. But you know what? We do what we got to do. But what's beautiful about the lacquer fill is that it's a cannulicular gel, which is basically like a hyaluron that uses cross-linking. And so you basically put it into the cannula, into the cannuliculus, if you will, filling it up completely, and then it forms basically just to the shape of that person's cannula, which is nice because, you see granulomas, you have patients where they say it comes out or extends. This doesn't. It stays in there about 6 months. So this, nice cross-link hyaluronic gel basically forms in there. And, it's a little bit more costly than just putting in regular plugs. But the truth of the matter is it's much better for your patient. There's a little bit of a learning curve. So what's beautiful about our profession is that we get to practice. Are we talking? Yeah, we're talking practice. So I'm excited about that. And, cross-linking is a good theme. And doing things that are kind of customized is another theme that particularly goes to our guest. And one more thing that I'm kind of excited about is that Glaukos, the company that actually has brought us cross-linking, And for essentially for the cornea, they announced that the FDA has accepted their NDA submission for their Epioxa, which is essentially their Epi-on. So it's the next generation cross-linking eye link therapy. Our practice actually is involved in the clinical trials for that. And interestingly enough, we were involved in something called, I think it was like Epi-on USA or something. I don't know. It was about 10 something years ago. And, I'm excited about Epi-on. I'm excited about the cross-linking. And I'm also excited to bring in our guest. For those of you who don't have a pulse, then you don't know who this person is. This is Dr. John Gellies. I told him that I'm Jellies because he's got this massive mane of hair right now. But here's the other thing. If you don't know John, so he's the director of the Specialty Contact Lens Division of the Cornea and Laser Institute in Teaneck, New Jersey. The dude is like world renowned. He's got more initials and things and expertise. But the bigger thing is that he's always so happy. And John, welcome to the pod. Pretty excited to have you here.
Oh, likewise, Mark. Always fun. Always fun to be here.
So right off the bat, I mean, I got to ask you, I noticed that in 2023, you were in the Newsweek, America's Best Optometrist. What number were you? What number did you fall?
I was in the category that didn't qualify for a number because
Oh, that's adorbs.
hilariously, though, you're
Yeah.
going to love this one. So the woman who is now my wife that I was dating at the time worked for Statista, who is the statistics company that puts that together. And immediately, and this is maybe a month in from us dating, I go, "Do you have anything to do with this?" And she goes, "This was done." She's very German, so in a very stern voice, she goes, "This was done last year, well before I would have met you."
I thought you were going to just come in and say 9.
Yeah.
And it's funny because if you would have said that, then John, I would have said that was my number that year. Yeah. I was in 2023, I was number 9. Made my way up to number 6.
Yeah.
And then they decided, you know what? Bloomenstein's in the top 10. There is no way this is a legitimate, ranking of doctors.
We're done doing this now.
Yeah. Newsweek's like, bye-bye.
Yeah.
So John, okay, you work in a cornea and laser institute. I also work in a corneal refractive surgery center. What do you are you mainly specialty contact lenses, or walk me through a little bit of what you do through your day, so our listener can get a sense of where we're headed.
Yeah, so on Mondays, I come in, I do a little admin work for 6 hours, and then no, I'm kidding.
Wow,
basically, so I see patients every single day. We do everything from seeing patients to doing clinical trial stuff to doing manuscripts to writing research proposals to doing just about everything. And then there's teaching on top of that, whether it's the optometry schools or the ophthalmology residents that come through. And it's fun day to day. I mean,
John, are you mainly focusing on, I guess, problematic corneas, or?
Oh yeah. So for my portion of the practice, so we kind of look at this as being, the marriage of ophthalmology and optometry, and especially in the area of cornea refractive, right?
Okay.
So what we look at is, we specialize in keratoconus. That is our bread and butter. Obviously, we do refractive surgery, we do contact lenses, but the vast majority of my patients, I'd say over 95% of them, are keratoconics who need medical contact lens. So what I spend my day on is literally just specialty contact lenses, and then complex cornea after that. So, if your patient has had melts, has extreme exposure, has ALS, can't close the eye, those sorts of things. Those are the sorts of patients that we're dealing with. So it is really, in a lot of ways exceptionally rewarding, because these are patients that really have seen a ton of different practitioners, haven't been able to get something that solves them, has gone through the gamut of various different procedures, and they really need a solution to be able to really enjoy quality of life. And that's the incredibly rewarding thing about what we work in, is you really get to provide for these individuals in a way that very few people can. So it's I gotta tell you, it's also without any bounds. Like here, we're not we're not constricted to being having a an overlord above us going, you can't do that because that costs too much, or you can't do this because our bottom line can't take that, or other things like that. We really get to work to the extent of the technology out there and be able to provide what's truly the best for these individuals. So it's a really unique area to work in. It's
It
amazing.
sounds like it. I
Yeah.
mean, so the interesting thing to me is, you're working on this other spectrum that optometrists are not working at. So before we delve into, I want you to describe some of the things you guys are doing over at your clinic. Is there any? So I happen to be listening to the Mod Pod, and I'm going to suggest anybody. Cecilia Ketting is our host. What she does is she takes articles that were in the publication, and literally she just talked to a few doctors about keratoconus, and talking about diagnosing it. So give me just honestly like a 30-second thing that you notice that is one risk factor, or just something that you see the commonality, that as ODs it's either this is somebody who's headed downhill, you need to do something, or this is somebody early on. And before you use, I'm going to tell you that for me, I feel like Vogt Straya. Did I say that right? Vogt? Is it Voigt? How do you say it?
I've always said Voight, but
Yeah,
I'm
Voigt.
probably wrong.
Well, you also say your last name is Gellies when most people say Gellis, but that's okay. So let's Voigt, Voigt, Stria. Whenever I see Voigt Stria, there's a lump in my throat, and maybe I'm wrong. So, is there anything that you look at and say, "Oh, this is the oh crap response. We need to do something a little more
Oh man,
aggressive"?
I mean, I have. I mean, there's just so many that you could look at, but I just, I mean, I could rattle a ton of things off real fast that are just my red flags immediately,
Go,
just by
go,
history.
red flag this,
So,
red flag
family
this.
history. If I hear family history of keratoconus, you are immediately getting a topography. If you tell me I have any one of the itchy, wheezy diseases, my alarm bells are going off. You're thinking eczema, atopic dermatitis, you're thinking asthma, you're thinking apnea, those sorts of things, all associated with keratoconus, right? High levels. Eye rubbing, another one that I'm going, oh, okay, ocular allergy, right? Another thing that's kind of going off. Oh, my vision's changing. I have frequent vision changes. Oh, I've seen a lot of doctors. Nobody's able to figure out what's going on. My vision's just bad, right? All of those alarm bells are ringing. The ones that are really interesting, though, was we did this retrospective here that looked at gosh, I can't remember how many eyes it was. I think it was somewhere around 1,000 keratoconic eyes from our clinic that were patients who hadn't had any surgeries. And what we looked at was, characteristics of their manifest refraction, and then related that back to their SIMCAs and Pennicam tomography. And what we found was that oblique and against the rule astigmatism was associated with keratoconus at all levels. Didn't matter if you were mild or severe. Those individuals with oblique or against the rule of stigmatism, 2 diopters or greater, were associated with keratoconus. So when I start thinking, against the rule of stigmatism, I start going, oh, we should think about topography on that. The other one was, and this is the scary part, because when you think of like a primary care exam, right? You think, oh, we get an autorefraction, we get auto Ks. Our auto Ks should be catching these things, right? Auto Ks weren't correlated with keratoconus with the K max value until we got over 60 diopters on K max.
Oh, come on.
I'm dead serious. It was
Wow.
crazy. So, you're looking at these things that you go, what is our best, option for finding this disease, right?
Yeah.
Screen everybody, I mean, there's so many devices nowadays that are combos of topographers with aberrometers or, with autorefractors or whatever. There's no reason that you shouldn't be getting a topography on everybody, right?
Right.
So, and there was this really, really great study that we got to be a part of too, which was looking at keratoconus in the pediatric population, right? So Barry's group and Jen's group, or the International Keratoconus Academy and Illinois College of Optometry put together this study at ICO where they screened every single patient that consented to it with a Penicam that came into their pediatric clinic. And what we found was that there was a pediatric prevalence of keratoconus of 1 in like 330.
Wow. That's high.
Yeah.
That's really high.
And those are patients that we wouldn't have screened otherwise, So, the idea that we need to wait until a patient complains, wait until a patient is not seeing 20/20. I mean, that, we're waiting until they've lost vision to do anything, or to even look.
So do you think that, so I look at cross-linking as, maybe I'm just, a little, jaded because I've seen enough cross-link patients where I see that it really stabilizes the cornea. Do you think that, cross-linking is an opportunity for us to sit there and say, look, if we catch these patients early enough, we can maybe slow down or even just kind of halt the progression of this really sight-threatening condition?
Yeah, I mean, in the ideal world, if everything could go the way that I hoped it would go, right, where you had insurance companies that decided that, what, tomography screening for the pediatric population should be like colonoscopies for over 40.
Wait, I'm sorry,
Everybody,
over 40?
yeah, you get your colonoscopies, you get them prophylactically to be able to rule out colon cancer, right? What about the idea of doing corneal tomography on all your pediatric patients on a yearly basis? They reimburse it at what, $20? Who cares? You get that done on every single patient. And then you have this preventative treatment that can stop these individuals from getting to the need for a corneal transplant or for expensive specialty contact lenses or other things like that. You're in this position where you've now prevented a ton of disease. You've now improved the quality of life of these individuals, immensely. We want to get to the point where cross-linking is a prophylactic treatment for these individuals with early signs or even subclinical signs of keratoconus.
I actually had well, I'm going to be honest, I'm still reeling about the colonoscopy. I mean, I'm just going to put it in a box and send it in. So I think I might just do that. But I mean, you could have gone to hearing, you could have gone to but you went straight there. All
Hey,
right. Okay.
it's the best.
Hit it where it hurts. Yeah. Uh-huh. But I had a young child in my chair this morning. I told you we were part of the clinical trial, and he was unmasked. This kid went through a whole year, and he was part of the vehicle. And so it was an epi-on. And but the beautiful thing though is with the epi-on patients, you don't see that haze swirl that we see with the epi off, the long, painful, kind of almost arduous kind of journey they have. And it's almost like for nothing because it's like getting rust protector for your car in New Jersey, right? How do you know it's working? Well, you don't have rust on your car, I mean, so he found out, he got unmasked this morning and he just looked at me and he goes, well, is it worth it? Should I go through it? And because they get offered the real treatment at the end of the study. And I looked at him and I just said, I go, my man, I go, you're 14. I go, you want to stop this from getting to a point where when you're, 25, you're not worried about how special your contacts have to be, or am I still going to be able to drive a car? I said, so you have an opportunity that's afforded to not very many people. I go, there is absolutely no reason not to do this. So I totally agree with you. I have another question real quick. Do you differentiate between pellucid and keratoconus?
Yeah, I mean, yes, pellucid is marginal, right? By definition, it's within 2 millimeters of the limbus, right? If you look at the vast majority of what's qualified, I'm going to get on a soapbox here for two
All right,
seconds,
go
but
bring it. Because you know what?
I
I don't
mean,
think people differentiate.
yeah, exactly. But that's the thing is like, does it matter, right? Is the other thing on it, right? If you're wrong or you're right, does it matter, right? That's the other question. But first thing on this though is just definitionally, is there a difference between them? Yes, there is, right? When you look at anybody who's got a crab claw like appearance, take a look at where their thinnest point of their cornea is. If their thinnest point isn't down by the limbus, that's not pellucid marginal degeneration. That is keratoconus. And you know why it looks like that? If you used any of the different map scalings, you would see a difference. You would no longer see a crab claw. If you use like a Gaussian distribution of it, you'd look at it and you go, oh, it's actually just a round spot right there. You know, if you looked at an elevation map, you wouldn't see that. You'd go, oh, it's just an elevated point right there, just like every other keratoconic person. It just depends on the map that you're looking at. So use your thickness to determine whether it's pellucid or keratoconus. Now, does it matter? Is the question, right?
Right.
You
Are
know,
you going to treat it differently? Are you
yeah,
going to manage it differently?
not really. I'm still it's still a progressive keratoatasia, right? So it's
I think the ones that always throw me are the form thrust, because I think a lot of doctors just look and go, well, the cornea is thick, it's just got that funny looking,
oh yeah,
or vice versa. They look at it and say it looks like a cone. It's got to be keratoconus.
yeah.
Um,
I mean, the
so
magic of epithelial mapping has just like changed the game entirely, right? Like this idea of, oh my God, it's an elevated area, it's keratoconus. Well, is it? If we look at the tomography of this cornea, do we see that the epithelium is just hypertrophied in that one area? Maybe it's just dry eye, right? Maybe it's something else. Maybe it's some basement membrane issue, right? Could be a variety of different things that cause that. On the other side, too, you get these relatively normal looking corneas on their axial maps. But then when you look at their thickness distribution to their cornea, you go, wow, that really thickens up rapidly to the side. And you go, wait, even though they're 525 microns thick, that's a really abnormal distribution. This actually might be keratoconus, even though they're 500 and something thick, right? So it's one of those that the technology is totally making the difference these days. Like we're doing a clinical trial right now for the new Oculus OCT, right? And I have never seen images. Mark, you have never seen images like this.
I
Ever.
probably haven't.
No, it is wild. I got to tell you, it looks like a like a pathology slide. It is that level of detail. Like you can see, I mean, you can almost see individual epithelial cells in this thing. It is wild. Like your Bowman's layer is just there. You can see the endothelium. You can see everything. This thing is gorgeous. And there are certain things that you would read in the old literature and being like breaks and Bowman's, and you'd be like, well, who can visualize that? And now you can. So, but it's things like that where the technology is getting so advanced and so good that the ability to catch these things so early now is just becoming, a simple matter of adopting the technology.
Right.
You know?
I also hope it becomes a matter of where people invest in the technology. Hey, listen, talk to me about pros.
Oh,
Okay.
okay. Yeah.
You are the first and only Boston site person who's a prosthetic replacement of the ocular surface ecosystem. I'm not going to lie to you. I tried to be the second, but I didn't qualify. I don't even know what it is. What is it?
Yeah. All right. So before I answer that, I do want to touch on your myopia comment, which
Okay.
that is one of the other perfect reasons to adopt some of this corneal scanning technology, though. Like if you're going to do orthokeratology for these individuals, you got to have a corneal topographer, right?
Yeah, that's true.
And
Axial length.
exactly, like this is an overlapping population between the myopia population and the keratoconus population, right? So, it's the same people who develop the same thing. And, what is, rapidly developing myopia and, rapidly developing keratoconus have in common? Increases in prescription, right? So, you look at this and you go, look, we should all be screening them. This is just another reason why. That being said, pros, use of a large diameter, basically a scleral lens that is, used for a medical purpose. So kind of think of it like this. So pros is the treatment. The pros device is the device that you're using to deliver the treatment, right? So what we're doing with this is we are essentially, treating severe ocular surface conditions with a pros device, which is a extremely customizable scleral lens. Kind of imagine a scleral lens on absolute steroids. You can do just about anything that you want to this design. So that is pros. In addition to that, though, we do a lot of work with a variety of different types of lenses. iPrint is another one where you're using an impression, to create a 3D model and then, develop a lens off of that. But most recently, I think the most exciting thing in what we've been doing in scleral lenses has been wavefront guided optics. So, Mark, you've had a history in wavefront guided, LASIK.
Yes, I have.
Yeah. So, but this is actually giving, really, truly different results. Which is, in these patients, we did a clinical trial looking at this and we saw, a line and a half of visual acuity improvement on average for regular cornea patients and about a 50 to 60% reduction in higher order aberrations for these patients. So, you're
That's
taking,
impressive. Yeah.
yeah, right? Like you're taking
Mhm.
it from being on average like 20/25 minus to being 20/20 and, giving them improved clarity to their vision. This is like hugely impactful. But like those numbers don't matter. What matters is when we ask them their subjective response to
Right.
this. Did you prefer, the wavefront guided lens to your traditional lens? Almost every single patient said that they preferred the wavefront guided lens.
Wow.
Yeah, it was.
I mean, it's the old John Potter 20 happy,
Yeah,
I
yeah,
mean,
yeah,
we got to give the people what they want,
yeah. Exactly.
So
Exactly.
when you said the iPad, that's Christine sent.
Yeah, that's Chris's. Yeah.
Yeah, Chris was actually we did a webcast a long time ago. Yeah, pretty impressive. I think that thing is super impressive. So but the wavefront is better than that because you're hitting the high order and the
Yeah, so the
lower
wavefront
aberrations.
is kind of think of it like this, like these customizable lenses like iPrint and Pros, and I mean, there's a variety of different types of super customizable lenses nowadays. So, whether it's like a profilometry driven lens or anything that's kind of elevation specific, they're focused on fit, like getting a lens that's going to fit your eye really well. The wavefront guided optics can be added on top of virtually any scleral
So
lens.
they're like 3M, right? They just make it better.
That's exactly it, right? You're just adding the optical profile on top of whatever the scleral lens is. So if you wanted like the ultimate in personalization now, you use one of those elevation specific lenses so that it fits the eye super well. And then you add the wavefront guided optics on there for that individual's aberration profile. And now you have like really fully customizable lenses that are going to fit excellent and give excellent visual performance. It's super impressive. Like contact lenses these days are it's an exciting place to be.
John, is there ever a keratoconic patient that you would just like, yeah, contacts suck for you, let's just go with glasses? Or is that just me because I'm giving up on patients?
Nah,
Yeah.
nah. Nah, man, all the time. The thing is that I feel like we don't talk enough with our patients about comprehensive visual needs, right? We're so quick to say you have keratoconus, you need contact lenses. The reality is that patient is going to wear those contact lenses, and they're going to have to wear them for 18 hours every day, and they're going to come in with a red, teary eye on a lot of these patients going, my contact lenses hurt, but I have to wear them because I can't see, I can't function without them. The reality is we got to look at these as having three different visual needs. You have your uncorrected visual needs, your glasses corrected visual needs, and your contact lens visual needs, right? And if we look at this holistically for these individuals, we can address their uncorrected and glasses corrected visual needs with things like curvature, corneal curvature changing procedures, right? So things like topography guided PRK, things like CTAC, things like DALK, even, right? Well, if we don't want to go the corneal transplant route, let's just say it's CTAC and topography guided PRK, right? When you look at those are going to improve uncorrected and best corrected spectacle vision. And then you still need the contact lenses. But let's say, in the case of CTAC, for instance, right? In our clinical trial on that, we found that these individuals gained 6 lines of uncorrected visual acuity, right? Going from like 2400 down to like, 2080, right?
Wow.
So
They can drive in Sun City, Arizona.
right.
Beautiful.
But like the same thing with glasses, right? We went from 2080 to 2040, right? That's functional vision in glasses, right? So, and then you have their contact lenses that are going to get them the rest of the way, right? You want your 2020, your 2025, that sort of thing. That's what the contact lenses are there for. But you got to cover that whole gamut of this individual, right? So you got to think of it as, 1, 2, 3, right? First and foremost, the most important thing, stop the progression of their disease, right? After that, yep, work on the curvature of the cornea, right? Get them that improved uncorrected and spectacle corrected vision. 3, bring it home with vision, real vision, right? And that comes in the form of contact lenses, specialty contact lenses. That also can come in the form, though, of various different types of other surgeries, right? We want to do an RLE, we want to do ICL, those sorts of things. We can do that with those patients. And if they've had their corneal curvature optimized, you now are at the point where you can get real vision for these individuals. It's
That's
wild.
amazing.
Yeah,
Yeah.
it's crazy stuff.
Well, I think, for me, I mean, I'm walking away from this with a renewed vigor to start screening. John, it's been amazing. Thank you for coming on the podcast, and stay warm up there in New Jersey. And for those of you listening, get out there, start, think about comprehensive vision. Think about how we can help our patients, and just, it's all about, maintaining that good quality of vision and doing the best that we can, because that's where we're ODs, right? John, I appreciate you, man.
Likewise, Mark.
All right, everybody, you take care, and we'll see you next month. Don't forget, you can pick us up on the Mod podcast and listen to all the other podcasts that go by. Thanks, everybody.